Hello and welcome to the McLean County Community Behavioral Health Forum. We're happy to have you here again with us today on this very cold afternoon. My name is Kevin McCall and I am a behavioral health specialist with the McLean County government. I will be standing in for the Behavioral Health Coordinating Council Supervisor, Tricia Millott, who sadly could not be with us today. To start, I'd like to talk for a second about the forum itself. The McLean County Community Behavioral Health Forum is typically a one-day event consisting of multiple breakout sessions, but with the ongoing global pandemic, we have adapted our in-person format and are pleased to offer a wide variety of individual sessions related to behavioral health that will be offered through April of 2021. Please check out our website for a full listing of these sessions, which include topics such as COVID-19, restorative practices, coping strategies, and much, much more. All registration is free, and you can even register the same day. Sessions are held at varying times throughout the day to allow for maximum participation by our community members, but all presentations are eventually uploaded to the McLean County Behavioral Health YouTube page, typically in less than 24 hours when the session actually occurs. I will provide links for both our website and the YouTube page in the chat located on your sidebar. I would encourage you to check back regularly for new additions as we continue to add speakers for topics that have been outlined by our planning committee. And we hope that you continue to join us for the next several months. Even with a new look this year, the idea of free community education and sharing of ideas originated out of the Mental Health Action Plan, which was adopted by the 2015 McLean County Board. This plan originated out of more than 100 community members that identified needs and best practices related to behavioral health specific to McLean County. In these uncertain and difficult times, we believe that it is more important than ever to help provide education, resources, encouragement, or even simply recognition of life's challenges. During today's presentation, there will be time at the end for questions. We ask that if you choose to ask a question during the presentation, that you provide enough context so that question can be properly asked to our presenter at the end. Without further ado, I'd like to introduce today's speaker, Taylor Davis. Taylor Davis is the Behavioral Health Specialist for the McLean County Health Department, and Taylor's position is unique as within the Behavioral Health Program at the McLean County Health Department, there are no direct services provided. Taylor's role is to collaborate within the Health Department and within the community on initiatives that include behavioral health topics, such as mental health and developmental and intellectual disabilities. Taylor has almost 6 years of experience in the human service field, holds a master's of social work degree, and is a licensed social worker. So I'm going to go ahead and make you the presenter here, Taylor, and then the floor is yours. You can unmute yourself real quick, Taylor.
Sorry about that. Thank you, Kevin, for the introduction, and thank you for everyone that's joined us this morning for this webinar. Today, we're going to talk about trauma-informed care in the workplace specifically, but I just want to put that out there that trauma-informed care can be used or implemented in a lot of different settings and levels. It can be individually, among staff, within the community, and of course, the organization, which I will primarily go over, but also within the organizational level, I'll be focusing more on the staff to staff perspective, but I may have some highlights or examples given for it within organizations that can affect or how you, that can affect participants as well. And so these are the objectives that I hope that we reach today in the webinar. I hope that we can understand what trauma-informed care means or what it means to be trauma-informed and the principles of trauma-informed care. And then also I'm going to give some examples or some tools on how to become trauma-informed and examples of how we are using it at the health department. And then also understanding trauma-informed initiatives locally and nationally, because this is a growing initiative. Before we get started, I also wanted just to highlight that we're going to stay trauma-informed today versus being trauma-exposed. So the difference being that trauma-exposed is more on that personal boundary level, talking about personal traumas, living through that, kind of like therapy. However, we're going to stay on the professional level, which is the trauma-informed, and that's just being aware of our actions and our words that we use to with people and in our interactions. And then also we'll just remembering that resilience is a goal of practicing trauma-informed care. And becoming a trauma-informed workplace is a long-term goal. It takes smaller steps to get to that long-term goal. It's not going to happen within a certain like a certain time span, like 6 months to a year. It's really just a journey, and we'll go over that a little bit more later on in the presentation, but just being aware that it doesn't happen overnight. And so I wanted to go over the basics of what trauma is and the adverse childhood experiences study, which both of these are, it's really good to understand this information in regards to talking about becoming trauma-informed and trauma-informed care. There was an excellent webinar done within this forum earlier this week, I believe, on the ACEs and trauma. So I won't go into great detail, but I do want to make sure it is highlighted for those that did not attend, but also it's just good to review and have that knowledge. So trauma, this is the SAMHSA definition, and it's just easy to remember if you can remember the 3 E's, which are the bolded E words. So it's an event, a series of events, or a set of circumstances that is experienced by an individual as physically or emotionally harmful or life-threatening, and that has adverse lasting effects on the individual's functioning and mental, physical, social, emotional, and spiritual well-being. Another definition I like to throw out there just because it uses slightly different wording, but trauma occurs when a person perceives an event or a set of circumstances as extremely frightening, harmful, or threatening, either emotionally, physically, or both. So it's just important to remember that it's up to the individual if something is traumatic to them or not. I can't tell somebody what is traumatic to them and vice versa. It's also important to remember that trauma can be physically and emotionally harmful. It has those effects, both of them. And so events that can lead to trauma. Just try to think about that for a second, thinking of all the different things that can be considered traumatic. And again, I can't always answer that, or I can't ever answer that for anybody. They answer that for themselves. But I just like to kind of think of it in a broad sense on a spectrum. For those in the field, they may have heard big T and little t, but I just kind of, and I use big and small, the words pretty lightly, but I just like to think of trauma. It can be big events, it can be little events, but it's all considered trauma. So the bigger ones people kind of go to are certain kinds of abuse, divorce, death, and then also like smaller types of trauma can be maybe like a car accident or getting fired from a job or losing a job. It can be a lot of different things on a spectrum that I like to make sure to point out. And this is just one of my favorite quotes in the research that I have done on trauma-informed care. And I've kind of already highlighted this in the previous slide, but it is not just the event itself that determines whether something is traumatic, but also the individual's experience of the event. 2 people may be exposed to the same event or series of events, but experience and interpret these events in vastly different ways. So an example I like to share is a car accident. So 2 people can be in the same car, the same accident at the same time, but have very different outcomes to that. One person could drive the next day and the other person may never be able to drive again, or it may take them longer. It's the same thing, but the person perceived it differently. And so that's why it's just important to keep that in mind. And so I wanted to briefly go over the adverse childhood experiences study as well. So we went over the definition of trauma, but this study specifically is basically like the foundational study on trauma that really highlights the prevalence of trauma in everyday life. And so it's just important to have that information when we're talking about trauma-informed care. And so this study was done in the 90s, and the purpose of it was to correlate, see the correlation between adverse childhood experiences, which I'll go over what those are, basically the traumatic experiences that were identified in the study, and then that correlation between that and health and well-being into adulthood. And so it's really important to highlight who participated in this study, which I will then reference in a couple slides going forward. But over 17,000 individuals participated in this study, and almost 75% of those people identified as white, and about 75% had some college degree or higher. So it's just important to remember those specific demographics of those participants in the later slide. And these were the ACEs that were identified and studied in this, in the Adverse Childhood Experiences study. So these are the 10 that were identified, which when I went back and said big and small, and again, I use those words very lightly, but these to me can be like the big ones that people kind of just automatically identify as, yes, those are traumatic experiences. Whereas the smaller ones, people might not always identify those can be traumatic experiences. But these 10 were studied in this study, and basically it's a questionnaire that they had these participants fill out if they experienced these events before the age of 18. And so part of trauma-informed care is to be aware of trauma, and one of the tools that you can also utilize with proper training, of course, but you can also screen participants for the ACEs, and that can help identify their ACEs score, which then can help know what interventions are needed and services that are needed for them to properly serve them. And it's just important to note that original ACEs questionnaire had these 10. There are some updated questionnaires that have some other trauma-related topics in there, such as relational trauma and racial trauma. Just from my research so far, they're just not as widely used as this original questionnaire. And so these were the findings of this study. And the findings were that ACEs are common. Nearly 2/3 of adults had at least one ACE, and 1 in 5 individuals had 3 or more ACEs. So the more ACEs somebody had, the increased risk of negative impacts later on in life that person had. And so when I highlighted that of the 17,000 individuals that participated in this study, most of them were identified as white, and most of them had some college degree or higher. So within that demographic, ACEs were very common still. And so just to highlight that in other populations that may be more vulnerable, or such as like the female population, minority population, those populations could have higher outcomes of ACEs. And so this is just a nice demographic or graphic from the CDC, which shows how this can impact public health, and because I'm in the public health field. So adverse childhood experiences, and then these little pillars that come out of them can lead to chronic health conditions such as diabetes, heart disease, cancer, those things. It's also important to note the correlation between poverty and trauma. So it's the stress living in trauma can contribute to mental health struggles and interpersonal conflict. So if you look over on this graphic on the right, underneath in this tree, you have the roots, and that's like poverty and discrimination, poor housing, violence. And then above it, you have the adverse childhood experiences, which are the 10 that we went over from the ACEs study. And so it's like within these roots, those that are living in these adverse community environments may not realize they're experiencing trauma because that's like that's the normal. But it's continuing to create adverse effects and harm. And so then when you add adverse childhood experiences on top of that, that just means like those adverse childhood experiences could possibly be more impactful, and that person just may need more resilience to overcome things, more interventions in place, things like that. And this is a very popular graphic in relating to ACEs that I like to share. This is just kind of similar to the tree graphic we just went over, but it has a little bit more detail. It just shows how something can add one thing on top of another, and it's kind of like a domino effect. So if you have that generational and historical trauma, and then you add social conditions to it, such as like the adverse community environments, and then you add the ACEs, the adverse childhood experiences, that can all create disruption in neurodevelopment and social, emotional, and cognitive impairment, which then leads to a health risk behavior that can turn into a disease and disability and possibly early death. It's just important to know that that doesn't have to always be the cycle or domino effect. If the appropriate interventions are in place or accommodations for like unhealthy coping skills, it does decrease that risk. And that's all the purpose of trauma-informed care is, and we'll go over that later, but one of the R's of trauma-informed care is to resist retraumatization, so breaking the cycle. And so I wanted to also go over how trauma can affect everyday life and kind of relate it back to us as individuals. And so this is how it can really, how trauma comes out. Within our body, we can have headaches, fatigue, upset stomach. With like our thinking patterns or our mind, we can be irritable, have depression, worrying a lot. And then that in certain coping mechanisms can be drinking or working too much or under eating, affecting your sleep. And it's just important to remember that like chronic stress on somebody can have some of these effects of trauma. There may not be a medical reason as to why you're having that versus it's just an effect of trauma. And then also how trauma affects professionals, because that definitely is a possibility, and it is a risk that professionals need to be aware of, but also workplaces need to be aware of if they want to become trauma-informed. And we'll go over the benefits of trauma-informed care as well later on. But people in the helping profession tend or are likely to move into the helping profession just due to their own trauma. But by being in the helping profession, it's an occupational hazard of compassion fatigue, vicarious trauma, burnout. And so it's just important for organizations and professionals to evaluate their level of stress, but also organizations to support the professionals working there by doing various things. And we'll go over some examples as well later on. But for those that are not as familiar with these terms, burnout, that is the state of physical, mental, and emotional exhaustion resulting from prolonged stress in the workplace. So that's just kind of feeling numb, no emotions, exhausted, and that's definitely a risk. Secondary traumatic stress is the physical and emotional stress response to exposure to others' extreme or traumatic stressful events. So that's basically you're helping somebody and you're hearing their trauma or their high stress situations, and that like it's all, you get those feelings like almost like you're experiencing it yourself, and that then takes a toll on you as a professional. And then a combination between burnout and secondary traumatic stress or vicarious trauma is then compassion fatigue. And that's the deep emotional, physical, or spiritual exhaustion accompanied by acute emotional pain. And so that is a combination, like I mentioned, and it's like a difficulty to maintain that healthy balance of empathy and objectivity in the work. And then lastly, one I don't have listed on this slide that I just like to always mention is moral injury. And that is damage done to one's conscious or moral compass when the individual perpetrates, witnesses, or fails to prevent acts that transgress one's own moral beliefs, values, or ethical codes of conduct. So that may be just like we are trying to help somebody, but there's red tape and we can't, so it just kind of hurts us because we know it's right for them to have whatever is needed, but we can't do anything about it. And these are just some symptoms of secondary traumatic stress. And again, symptoms of trauma or effects of trauma look differently in every individual. But some examples are like difficulty in daily functioning, maybe not being able to remember certain things or staying organized, or motivation could be an issue, feeling numb or disconnected, just maybe going through the motions to get what you need done. Always being on edge or hyper vigilant, basically not ever being able to relax, like almost always being prepared for something negative to happen. And then sleep can be an issue, and your depressed mood can be an issue as well within symptoms of secondary traumatic stress. And so I always like to try to find data that can be compared to what I am saying or backed up to what I'm saying. So this is some relatable statistics to professionals in trauma. 1 in 5 US adults experience mental illness, and 1 in 25 US adults experience a mental health disorder. And a little over 15% of master's level licensed social workers meet diagnostic criteria for PTSD, which is twice the rate of the general population. So I know not everyone on this call or who's going to be listening to this webinar are master's level licensed social workers, but it's a relatable statistic still, in that being that assuming that we're all in the helping profession, even though, again, trauma-informed care can be implemented in a lot of different areas, but it's still a helping profession. The social workers don't have to be just in public health or just in clinical work. It can be in a lot of different areas. So this is still a relatable statistic to many. And then also 50% of mental health professionals report moderate to high burnout. So again, mental health professionals can be in a lot of different fields and areas. So still relatable. And then last one I want to highlight specifically is about 30% of first responders develop symptoms of depression and post-traumatic stress disorder. Okay, so we're going to go more into the trauma-informed care aspect going forward, but I just wanted to give some of that background information on trauma, and then the ACEs study, but then also how it relates to professionals. So hopefully that's good foundation for the rest of this presentation to make sense and how to relate it to your work. And so resilience is the ability to rise above or bounce back from adversity, using available resources to address the hardship or consequences of an adverse event. And this can be applied to families, communities, and providers. And it's just important to know that resiliency is the key or a key tenet of trauma-informed care. So a good example I like to, this pandemic we're all going through, agents organizationally, a lot of organizations have had to be resilient and bounce back, and so they've had to alter certain ways of doing things and rethinking processes to still keep going, and that's a sign of resilience. And that's so that is how it can relate to communities and providers specifically. And so there's three main aspects of resilience, and that's social support. So that's those that are in that person's circle, in that organization circle, community circle. Also, part of resilience is getting back to normalcy. So that's like resuming day-to-day tasks that can create some sort of structure, even with some adjustment. So kind of like I've already said, but a lot like organizations have had to work around getting back to some sense of normalcy, especially after like the lockdown last spring, and we were able to kind of come out again. We still had masks and the hand sanitizers. We adapted, but we were still able to get back to some sense of normalcy. And then also meaning making. A very common example of this is an event occurred, and this is it gives a meaning behind it. So this event happened, so I'm a better person, or this made me stronger, or more flexible, or whatever you want that meaning to be. That's part of resilience as well. And it's just important to note that if you experience trauma, no matter on what level, if it's individual, community, or worldwide or organizational wide, we're not condemned to like a life of hopelessness or helplessness. People do recover, can recover from trauma. Same with organizations, community. It's just healing happens in relationships, and it can just be that one person. And that's where this trauma-informed care really comes into play, because it can just be that one person that makes a difference by something they said or did once, twice, several times for a long period of time, but it just takes that one person to make that difference. And also part of resilience or being affected by trauma is protective factors. And if you're not familiar with that, there's protective factors and risk factors. And so risk factors are things that set you up to have a higher possibility of experiencing something, and protective factors they literally protect you from experiencing something or overcoming something. So your community can make a difference. Also your social support, friends, family, but it's also the individual that can make a difference, and that person's cognitive abilities and healthy coping skills. Those all can be positive things that help people overcome trauma. And also with this asterisk, culture can play a key role in resilience as well. Certain cultures have reasons for why things happen, or meanings of things that happen. So that can really be a positive thing. And so this is what this webinar is going to be all about the rest of the time, is just what is trauma-informed care exactly? And so trauma-informed care, by definition, is an organizational structure and treatment framework that involves understanding, recognizing, and responding to the effects of all types of trauma. So basically, it's a culture and it's a mindset. It's not necessarily talking about trauma, but it's recognizing the need to create a physically and safe environment, and then also have the person or whatever level have choice and control in the decisions. And by doing that, you're understanding the foundation of where somebody's coming from, per se, the trauma. You don't even need to know exactly what it is, but you're aware that how it can affect somebody, and then you're creating this safe environment and allowing choice. And then this quote on the last bullet that I really like is, rather than seeing trauma reactions as pathological, it reframes these reactions as adaptive. it's the individual's best attempt to cope with the experience of trauma. So it's important just to remember that as well, where you may say something or do something to somebody and you may not have had negative intent, but their reaction was not what you were expecting, or vice versa. And it can all be related to, that's just their natural reaction to trauma in their life that you may not have anything knowing about. It was just a trigger. And so it's just important to try to be mindful of that as well, that there's a lot of different reasons why people say or do something. And so I'm going to try to play this video. If it does not work, it will be in the presentation. I'm hoping it will. It's just a quick video, 2 minutes, I think it is, talking about trauma-informed care. And Kevin, just pipe in if it's not working.
We know that bad things happening to people is not new. Trauma has been around as long as people have been around. But every day we're inundated with new stories and images that continue to heighten this awareness. Trauma is ubiquitous, it's present and appearing everywhere. But today, the wonderful and perhaps challenging news is that we have research, science, and momentum around preventing and addressing this work. The Adverse Childhood Experiences Study showed us unequivocally that there's a connection between bad things happening during your childhood and adverse health outcomes in your adulthood. The nation is hungry to sort out how to operationalize and use this knowledge for the improvement of their agencies and their communities. But integrating trauma-informed care is a journey and not a destination. And what we do at the National Council is try to provide people a road after that journey.
Taylor, I want to let you know that now I cannot hear this part of the video. It was coming in for me okay if you can hear the part set off.
Okay. All right, no worries. We'll just keep going. I apologize, but it will be in the presentation. So there's 4 R's to trauma-informed care, and that's realize, recognize, respond, and resist retraumatization. So realizing is the first basic, like the first R, but first step, if you want to say it like that. And it's just basically realizing how common trauma is and the impact of what trauma can have on somebody. And just recognizing it exists. And then recognizing it is like being able to recognize the signs and symptoms of somebody that's experiencing trauma, or like that reaction that they may have, realizing that that could be possibly a response to trauma. Whoops. Okay. Can you guys still see my screen? Yeah, okay. And then responding appropriately. So if that's referring to certain interventions or just how you personally respond somehow, that is being able to properly respond. And then all of that just resists retraumatization, not being part of the problem, but just kind of stopping it there and you not causing more trauma. So there's 6 principles of trauma-informed care, and we'll go over them one by one with certain definitions that we use at the health department on these. So the first one's safety. So safety is when an individual is feeling safe, calm, and secure in the environment and interpersonal interactions, both physically and emotionally. So some examples, and I told you at the beginning I would focus more on staff to staff perspective within an organization, but there's a lot of different examples that you can use. But feeling safe enough to go to your supervisor if you make a mistake without being shamed or blamed, that's feeling safe. Feeling safe enough to be able to talk to a coworker about a struggle without feeling like that's going to be shared among staff within your agency. Physically, an example, kind of easier to point out, especially with the pandemic going on, but wearing masks, taking temperatures while at work, people working split shifts or working from home, even the hand sanitizer. There's a lot of different ways you can physically feel safe. Trust and transparency is the second principle. And so within our actions or interpersonal relationships, trustworthiness is defined as having honesty and sincerity, and transparency is defined as being open and accountable. And so this is really just not having the whys or gaps of information, or in relationships, people not filling in the blanks if they don't know something, but just being basically just putting it out there, and people can feel safe within that by being trustworthy and transparent. So an example could be if my supervisor tells me, Taylor, you're working 2 to 9 for the next 2 weeks. I don't want any questions about it. It is what it is. Like, there's going to be a lot of like, I'm not going to be happy about it. There's going to be a lot of like questions on like, why is this happening? What happened? Like all these things. Versus if my supervisor were to tell me, hey, Taylor, I need you to work 2 to 9 for the next 2 weeks. We're short staffed. I know it's not ideal, but I appreciate you being part of the team and helping us out. Like, I may not still be very happy about it, but there's like all these answers, like all these questions answered. So like, she recognized it wasn't ideal. I know because of staff shortage. Like, there's reasons the gaps are filled. And as far as organization wide or as a supervisor, it's just important to note, like, you can still be trauma informed even if the staff person doesn't agree or like the decision. So like, based on this example, I wouldn't like working 2 to 9 for the next 2 weeks. However, that it can be trauma informed if she delivers that message in a trauma informed way, which by giving me the whys and the hows and acknowledging it's not ideal, those are filling in those things. Peer support is the third principle. And so that's interpersonal relationships that build safety, hope, and trust, enhance collaboration, and utilize our stories and experiences to promote connection. So having a buddy to share things with within your team, celebrating the wins and what can be achieved, like setting goals together, but also normalizing symptoms of trauma, or if we want to even take it, not using the word trauma, just normalizing symptoms of stress and bad days within the team. Example, being able to go to a coworker and ask them a question because you know they know more about that subject, and leaning on each other when you need to without seeing it as a deficit or a weakness, but just that everybody has their own strengths that we can utilize. Collaboration and mutuality is when the environment allows healing and meaningful sharing of power and decision-making in relationships. So the best example I have is like in a meeting, or not a meeting, but say like a group of any kind. We can go with like a work group, and there's people of all different levels within the organization there, staff, supervisors, leadership, but they're coming together and to collaborate to make decisions that the work group is going to promote or utilize. So basically, it just, like, titles matter, but there needs to be people in place that move things forward with those titles, but those people don't always have to make the decision. Like, you come together and it's collaborative, like a supervisor and a general staff person, they can share ideas, collaborate, and those ideas are put out together, if that makes sense. There's no power differential. Also, like, another note on this, which can be helpful to understand, is just having like that collaborative spirit that in place in being able to really openly discuss things when making decisions, or in knowing and kind of relaying if you're able to or not able to share certain things as a supervisor specifically. Empowerment, voice, and choice. And so this is when individual strengths, gifts, and talents are recognized and built upon. Everyone feels seen and heard, and there are opportunities to choose. So people like to feel like their voice matters, and they like to feel like people are listening to them, even if it's not, their idea isn't utilized or whatnot. There is a difference between not feeling heard and feeling heard, regardless if that is moved forward on. So this is when somebody feels like they just want to make it their job better, they want to grow in their job better, they want the organization to do better naturally versus just doing the bare minimum to get by, to get like that paycheck. It's more of the graphic on the right says it really well. It's just an empowered employee that just wants to keep making things better. And that just goes into a lot of, it has a lot of different effects as well. People can be more flexible, there's better customer service and good communication. And then lastly, the sixth principle is cultural, historical, and gender issues. And so many of you probably have heard of cultural competence, which that's more of the outdated term, the old term, where you're only looking at others' differences and being aware of them, where cultural humility is by definition here, reflecting and challenging our cultural biases and stereotypes based on race, ethnicity, sexual orientation, age, religion, gender identity, geography, etc., etc. Being open to learning about others and celebrating the richness of diversity in our relationships. So cultural humility is looking at ourselves and our own beliefs and opinions, but also looking at others too. So it's both ways. It's the updated way of, I don't like, it's the new and improved way is a better way to say it. And so those are the 6 principles of trauma-informed care. And by principles, it means if you're trying to practice all of these things, it eventually turns into that culture within whatever environment you are, and that turns into trauma-informed care. And just some side notes on the next couple of slides that I always like to incorporate is resisting retraumatization. So the 4th R of trauma-informed care, just a few things, just not forcing somebody to talk about their trauma. They may not be ready. If you just ask them how they're doing, that's okay. But if they don't really want to talk about it, just let it be for now. At least they know you're there. Don't tell somebody how they should think or feel about what they've experienced, what we went over already. Like, no one can tell me what is traumatic to me, and I can't tell them what is traumatic to them. It's all our personal definitions or our personal opinions. Not touching somebody without asking. And then also not using hurtful language. So using person first language. So putting the person before the condition or the diagnosis. Example being Taylor is autistic or Taylor is bipolar. You want to instead say Taylor has bipolar disorder or Taylor has autism, because those conditions they don't define who I am. They may be part of who I am, but there is a difference when you use that language. And just always focusing or always trying, practicing. Practicing is the key word of trauma-informed care, because we're human. We're not always going to be perfect. But focusing on strengths, life experiences. People know themselves the best. They know what they need. Individual health and well-being. Focusing on support systems. And just remembering at the end of the day, everyone has differences and respecting them. And these are some workplace practices. So just allowing vulnerability, acting with integrity, being empathetic, listening attentively. I know we are all very busy, just trying to just take that minute and really just not multitask, focus on what's going on listening. And then laughing together. I think that's just important to remember. Laughing has like this like natural effect that it just kind of changes that person's mood. If you're having a bad day, just try to like make yourself laugh, and there is some sort of positive effect that it does have. Okay, so what's the why? Why become trauma informed? It's not just something that people want to do. It is something people want to do, but that's just not the reason. There are specific benefits of becoming trauma informed. When I'm learning anything new, I like to always know the why. And so this is the why. Becoming trauma informed, it helps reduce burnout and compassion fatigue among professionals. It also creates safer physical and emotional environments for everybody. Clients, family, staff. Clients, family, and staff are also part of the community, which then helps the community as well. Resisting the possibility of retraumatization. So again, why be part of the problem if you can kind of stop that cycle, reduce some of that, reducing the traumatization. It also increases quality of services, because then you understand what services are necessary versus unnecessary interventions. So going back to treating a symptom that's for a medical reason, when it really has nothing to do with medical reason, it could have something to do with effective trauma. It increases client and family satisfaction. And then it also just reduces trauma symptoms, drug use severity, and mental health symptoms. And that is with everybody, clients and staff. So these are some of the things on what can happen if you don't want to become a trauma-informed organization, or if you just don't try at least or practice it. So you can have poor patient outcomes, poor employee outcomes, so maybe high turnover. There's more money spent in treating patients with things that may not be necessarily incorrect, but it just may not be completely seeing that whole person, the everything that can be treated, and lost revenue because you have the high turnover with staff, and just overall it just risks that organization's stability. Specifically, lateness and tardiness of staff, turnover. It's costly, $3,500 in this resource I found to replace a 1 8-hour employee, and that's with recruitment and training and everything that goes on that. Because if you think about it, it takes a lot to find the right person, a lot to train them, and then until they're, it takes a while for somebody to be per se like up and running completely in that position. Absenteeism, if an organization's not trauma informed, there could be bullying happening, harassment, the burnout and the stress, which we've already addressed. And that can cost organizations because people are calling off or not coming in, taking a lot of sick time. Just unscheduled absences, $2,600 to $3,500 per employee. But then also on the other hand, you can have people that are at work, but they're not being as productive and they're making mistakes or having poor quality of work. But being trauma informed, mistakes are not bad, but this is probably, and I don't know for sure, I didn't write this resource or in this information, but I'm assuming this means like unnecessary mistakes just because people just are not able to be fully present in their position. And these are some case studies for those that have actually tried to implement some sort of self-care, trauma-informed care of some sort. It looks different in a lot of different organizations. So a community hospital near Chicago actually created a stress management program that reduced employee turnover by 28%, or from 28% to 21%, sorry. And then Blue Cross Blue Shield of Tennessee, they did a stress management program and decreased exhaustion and this is what they've estimated that they're going to save in healthcare costs for their employees. So I'm a structured person. I like to kind of have like a linear idea of how to do something. This is the stages of becoming trauma informed. So there's 4 stages. Again, timeline, it's like we talked about at the very beginning, smaller steps to reach this long-term goal. But this is can help you measure where you're at in becoming trauma informed. So trauma aware, the first stage is just being aware of what trauma is, the impact of trauma for clients, for staff. Trauma is maybe referenced in informal conversations. People are learning about it. They're being aware is a big word. It's just like being introduced to it. Trauma sensitive. So this is where like you're aware of it. Now you're trying to be more knowledgeable of it. How do I actually practice being trauma informed? How do I apply this knowledge to everyday work life or life in general? This could be in a lot of different ways, but this could be exploring the principles of trauma informed care more in depth. How do you practice safety? How do you practice being trustworthy and transparent? How do you work on that collaboration piece? How do you be more aware of empowerment, voice, and choice? And this is more like just building upon that awareness, creating the knowledge, and then preparing for change, which then leads to being trauma responsive. So that's where you're trying to change certain routines and your the infrastructure of the organization, rethinking how things can be improved to be more trauma informed. And then lastly, once you get into the trauma informed stage, that's basically it's basically the culture. It's so accepted, you're almost not aware it's happening. It's just that's life. That's how it is. It's fully understood. Leadership's within it, and you're just continuing to. You've reached this mountaintop, and you're just continuing to try to stay on the mountaintop of being trauma informed. And so lastly, I just wanted to go over some tools of becoming trauma informed. Again, every organization is going to be different. At the health department, we've really focused on organization-wide, we're focused on staff to staff. Some organizations focus on services and participants or clients first, and then staff later, vice versa, or sometimes they do it together. There's a lot of different ways, and it's going to be, you have to tailor it to your specific organization. So these are just some tools. An organizational assessment to really be able to like survey where your organization is at in becoming trauma informed, so you have a baseline, and then you know where you can set goals to move forward from. You have to shift that culture to that strengths-based lens versus finding the deficits. So a big thing with trauma-informed care is instead of saying what's wrong with you, you're saying what happened to you. You want to have safety. Safety has to be in place before really anything else can be. You have to make sure that your environment is safe, physically safe, but also emotionally safe. And focusing on wellness and self-care, and then making sure everyone is included. So that is from general staff to supervisors to leadership. And if we're talking about a clinical organization, we're not talking about just clinical staff. It is everybody from maintenance to reception to call center, anything. Everybody's included. And these are just some local and state initiatives that have that I know of that I mentioned. Us at the health department, we've been working on it since 2019. So a little over 2 years. We've done an assessment to measure where we're at. So we've been able to set goals and measure those goals on our progress to be able to like keep moving forward. We have several committees that are focused on trauma-informed care, but different goals, and then they keep pushing out the mission on becoming trauma-informed. And then we also have staff do training. So we have all our new staff do a trauma-informed care orientation once they're hired. So they're at least aware of what trauma is and trauma-informed care to be able to move forward. And then we also have ongoing trainings for staff and supervisors and leadership to continue to learn the principles to move forward. McLean County as a whole is working on becoming a trauma-informed, resilient-oriented community. And then also Illinois has dedicated May 15th as Trauma-Informed Awareness Day. So that's pretty exciting. And it's also not just locally, it's nationally. In New York, there was a medical group that has worked on trauma-informed care, educating staff on ACEs, and also then screening patients for ACEs so they can better understand how to treat the individual or what interventions are needed. Getting patient input, focusing on employee wellness. You need your employees to be well to be able to serve patients. San Francisco Department of Public Health, they actually created a work group with experts and leaders to keep moving forward at becoming trauma informed. And they train all their employees, kind of like what we do at the health department. They also have trauma champions that like know all about this stuff and just keep passing the information along within the health department. So it's trying to be embedded within it. And they do mindfulness practices at staff meetings, so some sort of self-care within each team meeting. These are just some resources if anybody's interested in looking more into trauma-informed care. Relias has really awesome information. National Council for Behavioral Health does as well. SAMHSA, ACEs Connection, and Illinois ACEs Response Collaborative does too. And so this is my contact information if you have any questions. I know we're going to have a Q&A session in a second, but I just wanted to list my information in case there are additional questions that come to mind or if we don't have enough time to answer all of them.
Sure. At this time, if you go ahead and ask your questions in the sidebar over there, we'll give you a couple minutes to get those in, and then we'll ask them to Taylor here and see what kind of answers we got. I do have one question. I'm actually just going to ask the person here. Delana, it looks like you asked a question about a specific course that you couldn't see information about. Taylor, I don't know if you can recall a course that you were talking about, but she said she couldn't see it and wanted some more information about that. She had to log out and come back in.
I'm sorry, you were cutting out slightly. What course was she asking about?
That's what I'm not sure about. I'm trying to ask her as well. Maybe you can specify.
Okay. I know, like I was explaining at the health department, we have staff go through a training. I don't know if that's what she was meaning, but it's just an overview of trauma-informed care and also what trauma is. But yeah, if we can get more information, I can do my best to answer it.
Sure. Yeah, and again, to anyone that's in this call right now, if you have a question that comes up later, you can always reach out to Taylor. Or if you're watching this on the YouTube channel, weeks or even months from now, you can reach out to me and I can get a hold of Taylor to get you an appropriate answer as well. I do want to say that I really like talking about the more tangible and measurable aspects of being trauma informed. That's an interesting part of the presentation that I feel a lot of the trauma informed presentations don't really touch on. Taylor, could you just mute yourself real quick? I'm getting a really bad echo. So sorry, I'll probably have you unmute yourself in a second here too, but it's always good to see all the numbers and dollar signs kind of attached to these things to see how tangible it is to really have trauma-informed organizations, which I think is really great. One of the questions I have for you, and it's something kind of a theme that I've asked a lot of our presenters, just related to COVID, and how you think maybe some of past traumas may either flare up during COVID, or specific considerations to make for trauma-informed education, maybe in general related to COVID. I'm wondering if you have any comments on that.
Yeah, so I think just being aware that we're all kind of on this, I don't want to speak for everybody, but in a broad sense, we're all kind of on this like hyper vigilant level right now because we have this pandemic going on, and so we may be a little bit more sensitive to certain things that we weren't before. And so I think that's just where it goes into, we have to just be a little bit more mindful of what we're addressing, but then also when we're addressing it. An example could be like a certain a tougher topic may not be the right time right now. Let's maybe, even though it's super important, maybe just bring it up later, just because I think that would be my biggest answer. We're just, we're in this like survival mode. We can't handle everything we may be able to, we used to be able to. So just being mindful of that.
Yeah, absolutely. I definitely agree with that. It's all seemed kind of like a lot sometimes. Okay, so I don't have any other questions in, and I didn't get any further clarification on our initial question here. So I assume we'll probably get some more from some of our viewers here. Again, reach out to me or Taylor, and we'll get an answer for you on those questions. I'm going to go ahead here as well and post, like I promised at the beginning, the McLean County website information for further registration for upcoming sessions, as well as a YouTube page that should host this video. If you wanted to share it with anyone, hopefully within the next 24 hours here, we'll have that online. I want to thank you all for coming in today, and I want to thank our speaker again, Taylor Davis. That was really an in-depth presentation, and we really appreciate having you. Thank you very much, and I'll see you all at the next session.